differences between true and false labor. Okay, so I already said that there is regular uterine contraction. Okay, that is getting stronger with time. Okay, and you start to have pain, and starts at the back, and then rub around the belly. Okay, while on the other hand, the false labor, it's not regular, it's not strong enough. Okay, and if you change your position, sometimes the contractions stop. Okay, all of that. Okay, so let's get back to the question. So we have this lady, which is on 28th week of gestation. So to analyze the question here, I would like to know the diagnosis. So what are we thinking the diagnosis is here? Okay, always when you have a questions, try to think in a steps manner. Okay, so in that question, they need you to know the diagnosis, and they need you to know the management, which is already in the question, corticosteroid, and they are asking you how to prevent this, or what does corticosteroid prevent. So let's have answers in the poll, please. Yeah, let's go ahead. Let's have 20 seconds for the poll. Everyone answer. Those who already answered in the chat, try to answer in the poll as well. Okay. Okay. We have quite a good number, so let's have answers. 98% actually answered respiratory distress syndrome, and that's good. Okay, so what we're trying to prevent by giving corticosteroid is respiratory distress syndrome. Now, this is a question for the clever guys in there. Okay, so one of the things we're preventing with corticosteroid is respiratory distress syndrome. There are two other things that you can prevent with corticosteroid. Now, if you write in the chat, okay, what other things do we prevent by giving corticosteroid to patients, to babies with delivering preterm? Okay, brain injury. Brain injury is not very specific. Okay, intracranial hemorrhage. Good, Fatma. Good. Okay, so one thing is intracranial hemorrhage. I will accept brain injury as well. And the other thing is, anterior colitis. Good, Rahaf. Well done. Okay, so there are three things keep in mind that corticosteroid does, which is preventing respiratory distress syndrome, necrotizing anterior colitis, and intracranial hemorrhage. Well done. Okay. All right. Well, I like this class. Okay. So question 2. Again, a pregnant lady. This time is 34 weeks of gestation, presented with uterine contraction every few minutes. Okay. So when it says every few minutes, what's the diagnosis here? Is this true or false labor? It is mostly true labor. Why? Because if it's present every few minutes, then that's why one of the signs for true labor. Okay, and then we have the cervix is dilated, so that confirms our diagnosis, but the membranes are intact. Okay, the patient is stable, and the fetus has normal heart rate. What are the steps of management? Okay, keep in mind that the patient is presenting at what week? 34 week. Okay. Again, so we've explained the diagnosis and clinical feature of preterm labor, but how do we manage this situation? How do we manage such a complication, okay? Or such a disease, or let's say complication. Okay, so the very first thing is that we in induction of fetal lung maturity by giving steroids, okay? And we can use tocolysis or tocolysis. Now, it's important here to know when do we use this, okay? So bear with me for a second, okay? Mohammed, you can put your question in the Q&A and we can answer it at the end, okay? So there are indication and contraindication for using tocolytic medication or tocolysis, okay? It's important that you know the indication and contraindication because the management will change based on the presentation of the patient. Okay, so one of the indication is, of course, to enable administration of corticosteroid. Okay, so we give corticosteroid or transport the patient to another medical center. Now, the contraindication for this, okay, forget about the indication. We give for lung maturity. That's the indication. The contraindication is non-reassuring fetal CTG, or intrauterine fetal demise, or infections like corneal amnionitis, or antepartum hemorrhage, or or severe preeclampsia or eclampsia, okay, or fetal anomaly. So all of these are contraindications to give tuberculosis, okay? So if you have these, you do not give, okay? Now, preterm labor actually can be prevented, okay? And so this is it's a bit advanced, but it's good to have this in mind, okay? So it can be prevented by managing cervical insufficiency and by giving progesterone supplementation, okay? So there are details into there. So when do we give actually, at what week, and a lot of details in there. But for the sake of examination, okay, for the sake of SMLE, just know that it can be prevented by using vaginal progesterone supplementation and by also, what we call circulage, okay? So these are the two things that we use to prevent preterm labor, but there are indication and there are a lot of details there, okay? So let's go back to our question. So this is 34-week. We know already it's a preterm labor because it's presenting at 34 weeks, okay? Now, how are you going to manage this patient? Let's have the poll. So how are you going to manage this patient, okay? Let's have some answers. Okay, let's see some answers. Okay, so 70% answered, call the neonatologist, give her tocolytic and steroid. And that's the correct answer. So the correct answer is A. Some of you guys answered B and some of you answered C. Let's analyze this question together. So the thing you need to know, is there any contraindication mentioned in the question for tocolytic? No. Then you can give tocolytic, okay? And then you will give steroid. Is bed rest wrong? No, it's not wrong. You will have her resting in the bed, okay? But you need to mention about the tocolytic, okay? So here's the key to this question, okay? We're still in the topic, preterm labor. So I hope this question is clear, okay? So it's important that you give her tocolytic if there is no contraindication. That's the key word in this question, okay? So we're still in the topic and we're going to complications of preterm labor. So some of the complications are respiratory distress syndrome and what we call bronchopulmonary dysplasia. These two affect the lungs, okay? And we have patent ductus arteriosus, retinopathy of prematurity, necrotizing enterocolitis, intraventricular hemorrhage, anemia of prematurity. All of these are complications for preterm labor, okay? Let's move to the third question. So let's read the question, then we'll explain the topic. So we have a patient who's G2B1 lady. She's 14 gestational age of weeks of age. She's coming with true labor. We've already explained true labor. Now you guys are perfect in diagnosing true and false, okay? And she has also cervical dilatation. Suddenly, what's the diagnosis? Okay. Now, in this, it's 36, okay? No active labor, and 36 gestational age. What are we thinking? Now, this time, it's not only rupture of membrane, it's actually happening before 37. So this is going to be B-prone. Good. Well done. Okay, so we finished 3 topics. Let's move on. Okay, so this question, now it says G1B0 lady, 38 gestational age weeks. She claims that she had gush of fluid at home a few hours ago. Again, this is what? Rupture of membrane. But she's not sure what is it or from where it came. She has no regular or forceful contractions now. Doctors are actually confused if this was rupture of membrane and was amniotic fluid. So what we do is we can do some tests. We've done one, it's called nitrazine, and it was positive. What other test can we do? Now, if you guys are smart enough, you would tell me why I changed this. Okay, I see a lot of answers. That's fine, but let's analyze the question and then we'll explain the topic. Why in this question I had G1B0? Okay, because women or females getting pregnant, prima gravida, at the first time, they don't know what's the delivery or how delivery looks like. Okay, they can be confused. So she said, I had a gush of fluid, but I don't know what is it, because this is the first time she's pregnant and she doesn't know how delivery looks like. Okay, all right. So how do we diagnose rupture of membrane? We diagnose by examination, physical examination, and we call it sterile speculum examination. Okay, and when we do that, we would see a sign that is called positive pool. Okay, that is amniotic fluid exiting the cervix and pooling in the vagina. Okay, so that's the clinical diagnosis. It has to be sterile. Why it has to be sterile? Why it has to be sterile, guys? Because now there is no membrane and you're suspecting rupture of membrane, you could introduce infection. Okay, you could introduce infection to the mother and the patient and the baby. Okay, so be careful. Okay, and you will also detect amniotic fluid during sterile speculum examination. Now, there are some tests that we can do to ensure that this is amniotic fluid. One is mentioned in the question, and other name for it is litmus test. Okay, the other thing is Ferning test or Fern test, and we have something called IGF-1. Okay, insulin growth factor 1, and we have something called placenta alpha microglobulin 1. Okay, so there are 4 tests that you can do. Now, is this clinically relevant? I mean, it's done sometimes, but most of the times we diagnose clinically. So you know the names, for examination purposes, and you need to know at least the names. Okay, here. So if it comes in a question, you could answer it. So let's have the bull. This is an easy question now. Let's have the bull. What are we thinking? How can we diagnose this? All right. But one test, let's say, but one test is enough to confirm, right? Yeah, I would say one test is enough. Yeah, but if the question asks you, so what other tests, then basically they want to examine your knowledge of tests. So that's why you would say the other test. Yeah, clinical examination sometimes is enough. Okay, so 95% answered Fernic test. Very good. Some of you answered ultrasound to detect oligohydramnions. Okay, this is not the way. Answer A is not the way to diagnose rupture of membranes. Okay, good. So again, back to this lady. She's G2B1, 38 gestational age. She has rupture of membrane, but she does not have regular or forceful contraction. They already tell you the diagnosis, and they tell you that she's stable. How would you manage the patient? So what we're going to talk about is management. No, let's not have the ball at this time. Can we withdraw the ball? Just end it and do it again at the question. Okay, so management of rupture membrane. So we divide this into stable patients and unstable patients, okay, based on the presentation. Because rupture of membrane, sometimes patient can present, they are unstable and the case is too serious. Okay, so you need to know whether they're stable or not stable. Okay, so unstable patient, the diagnosis is based on gestational age. Okay, so if the patient is more than 37 weeks, so they are at term, okay, you could wait. Okay, you could wait for 24 hours. Why do we wait? Because if rupture of membrane happens, we are expecting labor to happen in the next few hours. Okay, we could wait. If there is no labor in 24 hours, no spontaneous labor, we can induce labor. We can do what we call induction of labor. Good. Okay. If the patient is not at term, if the patient is from 24 week up to 37 week, what do we do? Now the patient is what? Is not term. So what we call expectant management. Now be careful. Expectant management is not the same as waiting. Expectant management, you have something that you do. Okay, so you would ask for bed rest, pelvic rest. You would administer prophylactic antibiotics. Okay, and you would start what? The corticosteroid that we mentioned. Why do we start corticosteroid? Because now she's not having, we know that we use tocolytic and corticosteroid and what? In preterm labor. And this patient, she's not in labor, right? So why do we use corticosteroid? Again, because we are afraid of the labor happening. It's for lung maturity, yeah, but we are afraid of the labor happening in the next few hours or days. And that's why we want to give corticosteroids. So if there is labor, at least we would have lung maturity and prevent other complications. Okay, that's why. Okay, tocolysis can be used if the patient is stable, only to administer the corticosteroid, so that the corticosteroid can be administered. Now, and sometimes we do give magnesium sulfate. Okay. All right. And stable patient. Now here it gets a bit tricky. An unstable patient, you have stressed mother or stressed baby or whatever sign of instability, no matter what the age of gestation, the management is what? Is from delivery. Okay, you want to deliver because they're unstable. If you keep the pregnancy, either the mother or the baby can die. Okay, so what are signs that makes you concerned and think this is an unstable patient? Infections, placenta abruption, cord prolapse. All of these are signs of instability. Okay, signs of fetal distress, an unreassuring heart rate. Okay, these are signs of unstable patients. You will promote delivery and you will commence empiric antibiotic because sometimes you are afraid of infection as well in such a case. And because infection is one of the risk factor for what? For rupture of membranes. Okay. All right. Now, tocolysis, we took the contraindications, but here is one important, that it's contraindicated in advanced labor. So you do not give it to a woman to a female which is already has cervical dilatation of more than a centimeter or has corneomyelitis or non-reassuring fetal heart rate or other contraindications that we mentioned earlier. Okay. So let's have the bull now. Let's see that just the keywords. It's 38 gestational age and she's stable. The mother and the baby are stable. So what are we thinking? She's term. She's stable. She's not in active labor. What are we thinking the answer is? Let's have 5 more seconds. Okay, let's see the answers. All right, so 76% answered observe, and this is the correct answer. So watchful waiting, observation is the same meaning. Okay, so you will observe. She's at term. Okay, there is no need. Okay, she's at term already, and she's stable, so you can observe. We are expecting her to deliver within the 24 hours. Now, if that prolongs more than 24 hours, we can induce the labor, which is answer B. Okay, good. All right, question 6. Now, pregnant lady in second trimester, her abdomen is larger in this pregnancy more than previous pregnancy. Ultrasound done and showed twins. What's the time interval between ovulation and cleavage in dichorionic diamniotic twins? Now, this is very important. Bear focus with me. This is very important, and it gets difficult to understand. Okay, so let's explain the difference between monozygotic and dizygotic twins. Okay, so monozygotic, how it happens? The fertilized egg divide into two, and we have two babies. Okay, so you have one sperm, one egg, but it divides at some point, and then you have two babies. Fraternal twins, or what we call dizygotic twins, you have two sperms, okay, and two eggs, two oocytes, and two babies. Okay, so if I ask you this, we have twin, and they are different in sex, so one girl and one boy. Is it dizygotic or is it monozygotic? It's di. Exactly. It's always dizygotic. If you have different sex, different genders, it's dizygotic. Good. If you have same gender, is it dizygotic or monozygotic? Those who answered, Di, Abdullah, Ayman, I want to see your answers now. Same gender, is it? Can be both. You guys are very smart. Well done. Okay, it can be both. So any question that you see, different gender, different sex, it's always what? Dizygotic. It means you have two sperms. If it is same sex or same gender, it can be any. Okay? All right. So that's the point I want to highlight here. The things you can read on your own. Okay? And just one more point. If it's dizygotic, it's always dichorionic diamniotic. Agreed? Agreed. Okay. Now what we're going to explain further. Now this is easy. Dizygotic, khalas. What about monozygotic? It has further explanation. So what we're going to explain next is always what? Monozygotic. Now, if the egg, this is the egg, okay? This is the egg in day one. We have chorion and we have amnion. Good? Now, if it divide in the very first 3 days, okay, we have dichorionic diamniotic. It's similar to what? It's similar to dizygotic when we have two sperms. This is in the first 3 days. If it divides in from 4th to 6th day, we have monochorionic diamniotic. So the twins are as long as they're staying together, yani if the twins staying together for 4 to 6 days, it's like they become more intimate. They are sharing more things. So in here, each one has its own chorion and amnion. Because they divided early. They shared it for more days. They did not divide early, so they shared the monochorionic, okay? So it's one chorionic diamniotic. If they still together from the day 8 to day 13, it will become monochorionic, monoamniotic. And if it lasts further than 13 days, we call it conjoined twins. Conjoined twins. It means they are attached together. Okay. Now, okay. This is just a summary and an explanation of what I've explained. Okay. I think it's now clear. You should understand it, and you can read it on your own. But what I have done for you, I have given you something like to help you memorize this. So first 4 days, separate placenta and separate amniotic sac. Second 4 days, shared placenta. Third 4 days, shared amniotic sac. and after that it's conjoined twins. So let's just try to help each other by divided into 4 days. 4 days, 4 days, 4 days. In the first 4 days, everything is separate. Second 4 days, they will share the placenta. Third 4 days, they will also share the amniotic sac and the placenta. Okay. Now, we diagnose this by physical examination and by ultrasound. Ultrasound is important because we have 2 important signs. If we have dichorionic twins, we have what we call lambda sign. And if we have monochorionic twins, we have what we call T sign. Now, this is what? This is the T sign. Okay? It means that these are monochorionic twins. Okay? And this is what? This is lambda sign. You see how it looks like? This is lambda sign. This is dichorionic twins. Okay? And this is fetus, placenta. Good. So back to this question. It says here, in dichorionic diamniotic twins, when does the cleavage or the division happen? Okay, let's see answers. Let's give it 10 seconds. It should be easy at this moment. Okay, let's end the poll and see the answer. So 75% answered A, which is the correct answer, and I'm actually happy with this percentage. I know this tend to be difficult sometimes, but again, if you read and if you follow the rule I gave you, it should be easy. Okay, good. Oh, good. So question 7, same patient in previous scenario had the twin, right? She's now worried about the kind of delivery in her situation. So what's the best presentation for vaginal delivery in case of twin? Is it cephalic? Is it breech-cephalic? Is it breech-breech? Or transverse-cephalic? So in multifetal gestation, the management is important, okay? Most of the times, what we do is we do a cesarean delivery. Why? Because vaginal delivery has a lot of complication in twins. So unless they present in a favorable situation, otherwise we would do cesarean section. So what are the indications? Either monochorionic, monoamniotic twins pregnancy between 32 to 30 weeks of gestation, breech presentation, or significant differences in fetal weight. Now, those who are interested in gynecology and obstetric would know what does this sentence mean. Why there's differences in fetal weight? There are some diseases that could happen in terms of twins and give us difference in fetal weights. So one is big, one is light, and then we're suspecting something wrong is going on. That's why. Okay. Indication for vaginal delivery is diamniotic twins and above 32 weeks with one fetus in vertex presentation. At least one fetus in vertex presentation. Okay. We don't prefer female pregnant with twins to go beyond 38 weeks of gestation because the babies are getting larger and the delivery is going to be difficult and there could be complications. So if a female is pregnant with twin and it's dichorionic diamniotic, we can induce pregnancy at 38 weeks of gestation. Okay. And don't forget that for vaginal delivery, it has to be diamniotic, 32 weeks, one fetus in vertex presentation. Now, what's the answer here? I know I did not give you this clearly in the management, but I give you a hint. And based on that hint, you should be able to answer this question, okay? So let's see some answers. Okay, let's end the poll and see the answers. All right. Again, 73% answered A, which is the correct answer. But some of you answered B, breech and cephalic. Now, I would understand those who answered B because they think it's cephalic, and I said one should be one fetus in vertex presentation. However, in here it says, what's the best favorable presentation? Okay, so the best favorable presentation is cephalic. However, breech cephalic, can they deliver? they could, but they could have a try. Okay, they could have a try, but it's not favorable presentation. Okay, and there are complications. So if we have experienced doctors, if we have a good setting, then we might go, but most of the time we don't go. Breech cephalic, we don't go. Okay. Okay, Abdullah is saying it has to be cephalic breech, not breech cephalic. Okay, you can look into that and make sure. Okay. All right. So question number 8. Pregnant lady who's RH negative, and I suppose you all guys know what's RH negative. This is her first pregnancy. She was told she needs to take something called NTD. The attending physician is asking you as a junior doctor, when do we give anti-rhogram? Okay, so let's explain the topic quickly, and then we'll answer. Okay, so this topic is the title is aluminization and hemolytic disease of the fetus and newborn. Okay, so we have this. I'm just gonna summarize because there's a lot of text there. Okay, so we have differences and blood grouping. Okay, and what we call also the RH or the rhesus. Okay, between the mother and the baby, then this can give rise to what we call hemolytic disease. Okay, so of the fetus, the fetus can have hemolysis. Okay, and what are the etiology? What other things can cause this? ABO incompatibility. Okay, so different blood group, RH incompatibility, and we have rare condition called kill blood group system incompatibility. Now the last one is actually something advanced and it's rare. So just forget about it. Focus on the number 1 and 2. And the most important thing here is number 2. Although it says rare, it's rarely happening nowadays, but it's all because what? The anti-D. Okay? The anti-D. Okay, I'll try to slow down, but the time is not with us. Okay? So how does this happen actually? The mother will develop antibodies against the fetus blood. How? The fetus blood will mix with the maternal blood. If that happens, then the mother will develop antibodies. Okay? Does it usually is the fetus blood supposed to mix with the mother blood? No, but it happens anyway. Why? Because there are some procedures that can lead to this happening, including antenatal procedures or complication. I'm going quick. You can read on your own, but this is why it happens. Okay? So when we say most of the time this disease happens in the second and third and fourth and fifth pregnancy, it does not happen in the first pregnancy. Why? Because the mother will develop something called antibodies, and you know the antibodies. It's IgG and IgM and other types. Our system developed IgM the first time it encounters something weird, for example. But the second time they will produce IgG. Now IgG can cross the placenta and go to the baby, to the fetus, and destroy their blood cells and have hemolysis. Okay? So in ABO incompatibility, the highest risk when the mother is blood group A and the newborn has blood group of A or B. And in RH incompatibility, it happens when the mother is RH negative and the baby is RH positive. Good. So what are the clinical features? We have clinical feature for prenatal and postnatal. So the prenatal, we have hydrops fetalis, and this is a topic for another day. It's very big and it has a lot of details. Okay. Postnatal, we have neonatal anemia and hepatosplenomegaly. Good. And also we can have neonatal jaundice. And this jaundice will be characterized as in the first 24 hours. And I know you guys know this is what pathological jaundice is not physiological because it's happening in the first day, and it will be unconjugated because it is what? Hemolysis. Other postnatal clinical features include hypoxia, prematurity, and what we call petechia. Okay, so how do we diagnose this? It requires evidence of hemolysis and fetal-maternal blood incompatibility. So prenatally, we diagnose this using ultrasound, and we diagnose this by hydrophysically consuming. So it's super easy to prevent it from happening rather than treating it. And we will know this in a bit. Okay. So this question is telling you that this case is known case of RH immunization. So the mother is sensitized already, right? So they're asking you, and the fetus now have anemia. What's the next step? So let's discuss this. And I told you it can be prevented. The difficult is the treatment is just it's difficult. Okay, so prevention by giving anti-D, and that's it. You can imagine, give anti-D, you've prevented the things, and that's it. But you have to do it before the mother is sensitized from the very first pregnancy. Okay, so this is prevention, giving anti-D, and it only work in unsensitized mothers, right? And it has to be done when we have these things. And if I ask you why, for example, miscarriage or ectopic pregnancy, because these things can induce what? Mixing of blood between fetus and the mother. All right. Now, this is the standard dose for it. Okay. Now, treatment. This can be treated. It has to be treated prenatally and postnatally. Okay. You can see that things starting to get difficult just from the very beginning. Okay. So prenatally, you have to do what's called intrauterine blood transfusion via the umbilical vein or umbilical artery. Okay. You see from the name, blood transfusion to the baby, intrauterine. You see, and you can give IVIG in severe cases. You see how things can be difficult. Now you have to transfuse blood. It was only what? Anti-D. Okay. Postnatally, you would do what? Iron supplementation. Sometimes you could transfuse backed RBCs to the baby. Okay. And you will need to treat hyperbilirubinemia with phototherapy. Okay. And you can sometimes give IVIG. You see the difference between the treatment and the prevention. And actually, the treatment is the treatment of complication because this condition cannot be treated. Okay, what you're doing here is you're treating the complication. You're treating the anemia caused by this disease. You got me here? Okay. So let's have the bull. Let's have the bull. Let's have the bull for the course for question number 9. Okay. So this is 33 weeks, pregnant woman. She's already sensitized. The baby has anemia. What's the next step in management? Okay, please do not choose give anti-D. Why? Because I already told you we only give anti-D in mother who are not sensitized. And in the question, it says a known case of RH aluminization. This means this is just a synonym for sensitization, okay? And it's for prevention. Okay, so let's see how many of you answered. Okay, so 90% answered fetal blood transfusion, and I agree with this answer. So the answer is C. And I told you D is not correct because the mother is already sensitized. Duplex is actually one of the we do it in the investigations, not in the treatment. This patient is already found to have anemia. They've already done duplex. We do not deliver immediately unless there is what? Indication for delivery. Okay, so the last topic is, the question says, pregnant lady, 42 weeks. Okay, on examination, cervix is 0. So 42 weeks, when you hear 42 weeks in a pregnant lady, you should have diagnosis in your mind. Okay, we'll explain that. Still, the cervix is not dilated, and there's no contractions and no signs of labor. How would you manage this patient? So the diagnosis here is what we call post. Well done, guys. You are writing the diagnosis in the chat. Well done. Okay, so Maha and Abrar. Okay, so this is what we call post-term or post-dated pregnancy. Please, Suhaib, write your question in the Q&A. We might answer it at the end. Okay, so post-term pregnancy is pregnancy beyond 42 weeks. or the estimated date of delivery plus 14 days. Now, this is estimated date of delivery plus 14 days is sometimes confusing because you need to make sure that your estimated date of delivery is actually accurate. Okay, so just keep beyond 42 weeks in your mind. Okay, management, how do we manage this? We induce labor. We induce labor. Since we're talking about induction of labor, let's see the indication and contraindication for induction of labor. So the indication can be the thing that we just took, post-term pregnancy, or premature rupture of membrane at term, okay, or hypertension, preeclampsia, any complication of pregnancy, maternal diabetes, intrauterine death. Contraindication, history of uterine rupture, placenta previa or vasa previa, transverse fetal lie, okay, cord prolapse, genital herpes, non-reassuring fetal heart rate. All of these are contraindication for induction of labor. Okay, induction of labor means going into vaginal delivery. We are inducing vaginal delivery. Okay, so just a quick approach. How do we do this? We have something called membrane sweeping. Okay, so it's like you sweep the membranes. Okay, in order for them to rupture, and if they rupture, they can induce the labor. Okay, you could give prostaglandin, or okay, you can give also oxytocin infusion. Okay, if the membranes do not rupture by sweeping, you can consider immunotomy. Okay, and there is a condition to that. You can read it on your own, but this is important. When you induce labor, you have to monitor the fetus throughout the procedure. Okay, this is very important. Okay, so let's have the pull. This should be easy. A post-term lady coming to you, no active labor. What's the management? It should be easy, right? So I'm just gonna give it 10 seconds. This is super easy, guys. Answer this, and then I will explain one more thing, and we're done. Okay. Let's see the answers. Let's see how many of you answered correctly. Okay, 86. I'm happy with the percentage. So most of you answered B, which is the correct answer. We will induce labor under strict monitoring. Okay. Now, the last thing I want to explain is, because here it says augmentation of labor. What is induction? What's augmentation? Induction is you induce, or you make the labor happen. Okay. So you stimulate the contraction before the onset of labor. So no contraction, nothing is happening. And what you're trying to do is trying to induce that. Okay. Augmentation is actually, there is labor, but you want to augment it. You want to help it. You want to speed it up. Okay. What's augmentation, Nora? Now what I'm explaining. Okay. That's what I'm explaining. You need to enhance the labor. You need to تساعد يعني لما أقول تساعد الولادة. البيشنت قاعدة تولد تمام, and you want to وانت حابة تسرع من العملية, حابة تساعد البيشنت. Okay, that's augmentation. Okay, sometimes how do you augment? How do you induce? I already explained here, right? صح? I explained here how do you induce. How do you augment? It's give or take the same things. For steps of induction, there are a few things that you can do, but we call it augmentation if there is active labor. Okay. So thank you very much for staying with me this time. I'm really happy that that I delivered this presentation, and thanks for joining me. I would also be happy if you guys have any question to answer. I'll answer a few questions now. Just things before you go. Thank you, guys. So what I want to say is believe in yourself. Okay, I know you guys going to do the SMLE examination soon, or you have some other examination, college examination, or whatever. And sometimes you think, will I do it? It's difficult for me. Well, believe in yourself. I know that if you're asking yourself this question, it's basically you are motivating yourself to do it. So you will do it. You will do it, inshallah. Okay. So please, guys, do not forget to fill the evaluation. It's important for me and it will help me improve myself in giving a presentation. I'm going to answer your question now. Okay, so why we give Tocolytic when she is 34 weeks, not steroid and deliver? Okay, why do we give Tocolytic? If she's steroid needs time to work. Okay, so steroids needs time to work. And if we don't give Tocolytic, she's going to deliver, let's say, for example, in the next 12 hours. So steroids need, for example, a few days to work. Okay, so that's why we give Tocolytic. If the patient is what? Is stable. Okay? Suhaib's saying, why not B or C? I'm sorry, Suhaib. If you write the question number, then I will go back to it. Okay? I don't know which question you're meaning. Okay? Okay. Could you repeat the rule of twins, please? Yeah, I will repeat it if we have time at the end. So why do not wait for 37 weeks at twins? I told you why we do not wait, because we don't want the twins to get larger or bigger in size, so the delivery will be difficult. That's why most of the time, if we have twins, we don't want them to get any beyond 37 weeks, so we can deliver them, especially if we're delivering vaginally. Okay, so that's the reason. Question 8. Zahra, I would like to go back to question 8 if we finish the question. At which trimester is anti-RH given? Okay, good. This is very good. Anti-D is given. There are specific times that we give anti-D. Now, correct me if I'm wrong, but what I remember is we give anti-D in 24 weeks. That's in terms of weeks. And we give anti-D if anything that happens from the things I told you, for example, ectopic pregnancy, miscarriages, trauma, or things like that. Okay, but please go ahead and search for that information. If everything is normal, we give anti-D, I believe, at 24 weeks, if I'm not wrong. Okay. So if father is negative and mother is negative RH, I think there's no chance of having a baby positive, so there is no need for anti-D. Is that right? I would say yes, but I'm not sure actually. Negative, but most of the time we do not test the father. Most of the time, this is more like genetics. I'm not sure. No. I don't think if both are negative. Well, I'm not in a better position to answer this, but most of the time we do not test the father. So this question in this way does not actually come in an examination. Okay, we only know about the mother. Okay, so I think my time is up. I'm just gonna end now. I'm sorry I couldn't answer all of you guys. If you still have a question, if you can ask me later on, or in if you can reach out to me Twitter or something, I will answer a question. So thank you very much. I think now you would have a break. Yeah. So thank you guys.